Thank you to everyone who signed on today, and a big thanks to Health First for sponsoring this. So I'm going to go back in time to 1988. I was filling in at the front desk of a general surgeon's office, and he would come back from the hospital and he would bring a card with him for every day of the week. And you know what he would write on it. He would write down the patient name and what he had done for the patient that day, and then he'd write down the diagnosis code. And Dr. Fabricant used to always write down not just the diagnosis code for the condition he was treating, like gallbladder disease, but he would write down the patient's underlying medical problems, diabetes, hypertension. And I said to him, you know, Dr. Fabricant, we get paid the same amount for that surgery if I put down one diagnosis on the claim form or four, because I was a lazy diagnosis coder and I didn't want to look up the other three. And Dr. Fabricant said to me, Betsy, I want the insurance company to know just how sick this patient is. And of course, the bubble over my head at the time was, but they don't care, but probably wrong even then. But in 1988, we were getting paid solely based on the CPT code. And now things have changed some. So again, thank you very much for joining us today. At the top of your screen, you have a chat box. If you're having any problems hearing or you can't find the handouts or any technical issues, please write a chat, and Tammy, who is the wizard at this program, will help you. And then there's also a Q&A box. And at the end of the presentation, I'll read the Q&A questions that I have. So I'll read those if there are any questions at the end of the presentation. There is a CEU credit for anyone who signs in and is here for the bulk of the presentation. The APC rule is you have to be here for the whole presentation. And there are two handouts for you because I want you to have plenty of paper. The first is a risk-adjusted diagnosis guide. It is a resource that I hope will be helpful for you. And then, of course, just the copy of the PowerPoints. So how are physician services paid? We're paid in fee-for-service medicine based on either the CPT code or the HCPC code that we submit, with, of course, some adjustments for modifiers. And how does the payer use medical necessity? I joke, to deny the claim, but of course that's not right. The payer uses medical necessity, uses the diagnosis code to establish the medical necessity for the service. In fee-for-service medicine, that's the end of the story, basically. We submit the CPT code, the diagnosis code shows the reason why, and we get paid for the claim. But now, many of you, all of you, if you're listening in on this call, have contracts with risk adjustment. So that means you'll still get paid the same amount for the claim that you submit, but at the end of a calendar or a contract year, the payer is going to look and they're going to see how much did it cost to take care of your panel of patients. And how do they know they're your panel of patients? They basically assign them to you based on claims. How sick were those patients, and what kind of quality or outcome measures can they determine based on claims? So even though if you are, which I know you are, part of an accountable care organization, or the other word for that is a Medicare shared savings plan program, or if you have contracts with commercial payers that have a risk-adjusted factor, then you still get paid the same amount on the individual claim, but at the end of the contract year, some of you may get paid slightly more, maybe you'll get a bonus, and some of you may see your payments decrease. And part of that is, how sick is this population of patients you're taking care of? So this risk adjustment that we're going to talk about today is a system that was developed by Medicare, in particular Medicare Advantage, to estimate future payments. So it's how the payer says, how much will it cost me to take care of this group of patients in the next 18 months? Most of us have had this experience with our Medicare Advantage plans where they come by and review records, or they want to know all the patient's medical problems. And that's because the Medicare Advantage plan is paid more by Medicare on a per member per month basis for sicker patients. So this risk diagnosis coding that I'm talking about today wasn't originally intended for physician payment use. It was a system to estimate future costs, and now some of our private payers, in addition to the ACOs, have this kind of review. When we look at some of the examples of codes that have a risk-adjusted factor, and I'll talk about how they get that and what that is, some of you physicians who are listening, and nurse practitioners and PAs, may say, this doesn't make sense. Why doesn't condition X risk adjust? Why isn't it considered serious? And keep in mind that this is a future-based program, and that I'm going to talk in particular about HCCs, hierarchical condition categories, which was developed by Medicare to predict costs in the next 18 months. So here I've just got an example of what risk adjustment is. It's this measurement to reflect the health status of patients. So what we're doing here, we've always been, some of you I know have always been very careful about your diagnosis coding, and you were like Dr. Fabricant and wanted to make sure you were describing the patient's conditions. And some of us, I'll just say me, maybe it wasn't any of you, were less interested in diagnosis coding. I wanted to get the CPT code right. But now with this risk-based diagnosis coding, our goal is to provide an accurate picture, a complete picture to the payer about the patient's disease burden, this individual patient, and then of course by extension the disease burden of our whole panel of patients, our whole group of patients that we're caring for. How is this calculated? Well, it's two things. It's such a complicated system. I finally gotten it down to two words: demographics, diagnoses. So the first four things on this slide you can't do anything about, because those come with the patient's age and gender, whether they're living at home or in an institution, if they have end-stage renal disease, and if they are dually eligible for Medicare and Medicaid. So using this HCC system, every patient has part of their risk score based on demographics. So a 65-year-old patient who's living at home will have a lower demographic base risk score than the 90-year-old patient who's dually eligible living in a long-term care facility. Some of these risk-adjusted formulas include prescription drug data. It's not used by HCCs, but it could be used by other plans. And Johns Hopkins has developed a proprietary system, and your ACO, according to Susan, is using this proprietary system. And it has a big advantage because the HCC model that I'm going to tell you about undervalues, I believe, pediatric and women's health problems because it was developed for a Medicare plan, a Medicare population. So the fact that your group is using Johns Hopkins, your ACO, is a big advantage. Now, having said that, it's a proprietary system, so we don't have all of the details of it. The underlying concepts work no matter which system is being used. So first, demographics, second, diagnoses. And the payer looks at the diagnoses that are submitted on inpatient claims, outpatient hospital claims, physician claims, and certain other healthcare professional claims data. So a social worker, a physical therapy claim. It doesn't use diagnosis codes that are submitted on lab or X-ray or any other kind of diagnostic test. So I'm just going to do a brief review. Clinicians, stick with me while I just go through very quickly these ICD-10 guidelines. We use the diagnosis that describes the patient's condition, symptom, complaint, or problem. We use the code that is chiefly responsible for the service that we provided, and we assign the code to the highest degree of specificity. I say, ha, ha, ha. Why'd they give us 70,000 codes if they wanted us to be specific? But what I do want to emphasize is, if it's the condition that you're treating, you want to be very specific. So if every specialty, if every physician who was treating the patient assigned the most specific diagnosis codes for the conditions they're treating, then those will all be reported to the payer. And in some groups, it ends up being primary care who has the burden or the responsibility for reporting most of the chronic conditions. But if it's something you're seeing the patient for or treating, then we want to pay special attention to specificity. We don't code suspected, rule out possible codes on a physician claim form. We code a chronic condition as often as treated. And then this is the guideline that I want to pay some attention to and that we'll come back to as we go through this next 45 minutes. Code all documented conditions which coexist at the time of the visit that require or affect patient care or treatment. So notice that the ICD-10 guideline doesn't say code all conditions that you're personally managing or treating. It says code conditions that are there at the time of the visit that affect your care or treatment. So we'll see some examples of that. It's important to remember that. And then, of course, we don't code conditions which no longer exist. That sounds fairly straightforward, but we'll look at some examples where we can tend to make mistakes when we do that. So this is important for specialists. We're going to code all the documented conditions that require or affect patient care. So if you are a surgeon and you are going to get the patient's primary care doctor or cardiologist to sign off on the patient to do a pre-surgical evaluation, that's affecting your care. If these are documented, if you document that in your assessment and plan, then following ICD-10 guidelines, we would add those codes to the claim form. Now here, it may be harder for you to be specific. So if you are seeing a patient and you're going to do a surgery, but you want the patient to go back to their primary care clinician, you may not have the specific diagnosis codes for the underlying condition. So code yours specifically, and then we're going to count on the primary care doctor to code those other conditions. If you're a cardiologist, you're going to be coding those cardiac conditions very specifically. And then if you need to send the patient to endocrinology for some reason, maybe the endocrinologist will code the specific diabetes codes. Although in cardiology, you're probably doing that too. So we're going to come back to this concept as we go forward. We don't code conditions that no longer exist. The example that I see most frequently of this is neoplasms. So if you have a patient who still has evidence of cancer or is receiving treatment for cancer, then we report the neoplasm diagnosis, the one that starts with a C, you know, breast cancer, prostate cancer, colorectal cancer. If you have a patient who no longer has any evidence of the disease and is not receiving any treatment, then we code personal history of malignant neoplasm. We'll see some other examples later in the presentation. And then leukemia, some of those are defined as in remission or in relapse. So assessment versus past medical history. So then if you had a coder, if we coders were coding the patient's chart, Would we code things that were listed up in the past medical history or the problem list? We wouldn't, because we would say, I don't know if this was addressed today. I don't know if this affects the treatment of the patient today. So we rely on the physician, nurse practitioner, physician's assistant to make those connections for us, to tell us that. And where might we see that? We might see it documented up in the HPI. We could see labs reviewed or prescriptions written. And typically we would see something in the assessment and the plan where your clinical thinking was just documents that you were considering the patient's other conditions while you were treating the main condition you were treating. So just because it's up in the past medical history doesn't mean that we select it as a code to submit on the claim form. And in most systems, the way we select a code to go on the claim form is those conditions that the clinician describes in the assessment and the plan. So usually those are synonymous. Systems work differently, so you have to check that. So we report conditions annually. One thing about the insurance companies, I say they have a short memory because the slate is wiped clean every single year. We've got to report all these patients' chronic conditions annually in order for it to count towards their risk score. For chronic conditions that have a manifestation or a complication, here's where we want to be very specific. So diabetes with nephropathy, Crohn's disease with hemorrhage, varicose veins with ulcer. So my quick and dirty, and you see this is these concepts work no matter what risk formula the payer's using. You report the conditions annually. If there is a manifestation or a complication, it can increase the risk score. So for some codes, varicose veins unspecified doesn't risk adjust, whereas varicose veins with ulceration does. So if that accurately describes the patient, you want to make sure if the word with is in the diagnosis code, you use it. And avoid unspecified codes for chronic conditions, particularly if you're treating it. And then we're going to look at some status codes. Only a few of those risk adjust. And remember, these are codes, these are conditions, ICD-10 codes, that are reported on a claim form to the payer by anyone. So in this guide, I de-emphasize major trauma, because if the patient has a spinal cord injury, they're going to be in the hospital, and the hospital is going to report that. And so that's why I focus on the things that we're doing here in the office. The code only has to be reported once by someone, either you as the specialist or the hospital because the patient had an outpatient visit to the ED, or by the primary care clinician. So when I'm talking to the primary care doctors, I encourage them to report once in a calendar year. And when I'm talking to specialists, I say it would be helpful if you're following the ICD-10 rule and you and the condition affects your treatment, if you reported it as well, just to be sure. All right, so chronic conditions, if they have a manifestation or a complication, we're going to use those codes, and then we'll get to the few status codes that risk adjust. So the first thing we're going to do is we're going to follow ICD-10 guidelines. We're going to ask, we coders will ask clinicians to document their clinical thinking. The surgeon sends the patient to cardiology for pre-op clearance. The ophthalmologist is treating the patient with diabetes with retinopathy, is being specific about the use of that code because that's the code that he or she is treating. And if there are medications or treatments that you're providing that are influenced by either other medications that the patient is taking or their underlying conditions, we're going to document. If you document that in your clinical thinking, then you can add them to the claim form. If you personally, physicians, nurse practitioners, physician assistants, are selecting the diagnosis codes in your EMR, then you're going to want to select each of those. So I'm just going to use the surgical one again. You're going to want to put in, Crohn's disease for the first and coronary artery disease for the second. There are some bigger groups where coders are looking at every bit of documentation and reading it. And in that case, you could just make a comment and your coder would pick it up. But mostly in private practice, the clinician, him or herself, is selecting one, Crohn's disease, then finding again number 2, the coronary artery disease. And if you're treating the Crohn's, I know you don't always know the specifics up before you've done tests, but you're going to be as specific as you can about that, and then we're going to hope the cardiologist is specific about the conditions that they're treating. All right, so what codes don't risk adjust? Some unspecified or uncomplicated codes for chronic conditions. Not all, some of them do. Symptoms, almost nothing that starts with an R, fever, chills, muscle pain, chest pain. Some of those are in the subject organ system and some in the R chapter. They don't. Conditions that may or may not be treated, like osteoarthritis, and then things that are definitively treated. So appendicitis doesn't have a risk-adjusted score. And you say, what? And the reason, of course, is this is a system to predict costs in the next 18 months. And something that was definitively treated isn't going to affect costs in the next 18 months. It's over. We've already paid for it. So if we were thinking about HCCs, these hierarchical condition categories, each patient has a composite risk score that is the sum of their demographics and the diagnosis codes that are submitted in the course of a calendar year. Now, if we were the Medicare Advantage plan, we would get paid more times their capitation rate for sicker patients. I'm going to talk just briefly about how these are how HCCs work, but you don't need to understand the details about how HCCs work if you remember the 3 key concepts. Report conditions annually. If the code has a manifestation or complication, report that and be specific about those serious chronic and acute problems, and report just a few status codes every single year. Again, those 3 concepts will take you through, even if you are rolling your eyes at the details. So we have about 70,000 ICD-10 codes, and I can never remember the number, 7,000 or 9,000 of them are grouped together in related conditions and given a risk-adjusted factor. And we'll see examples of that in the second handout. Related conditions are in the same one category, only one, the most serious one, is counted. We'll see an example of that. If there are 2 conditions in the same group, it only counts once, so they don't just keep adding up. Whereas unrelated conditions in different categories are both counted, and the score is additive. When I'm thinking about diagnosis coding and HCCs, I want to pay most attention to my most frequently reported codes. And here are some that you may or may not be treating depending on your specialty, but we're going to go back and we're going to look in the other handout in just a minute here for some other conditions. But Vermonters are pretty healthy. It ranks 43rd in states of patients with diabetes, only 8.4%. Whenever I go to a state and do this presentation, I look that up, and I've been in states with 14% of diabetes. 27% are obese. In the whole US, about 15% of us evidently are depressed, and coronary artery disease causes 30% of deaths in patients over 35. So we're going to be thinking about volume. Now, if you have printed out the other handout, the resource handout, I'd like you to look at page 21. If you have not, don't worry, don't run and print it out right now. Just I'm going to talk you through some of these pages. And then we're going to go back and look at some specific examples and what the risk scores look like. So when I was thinking about diagnosis coding in HCCs, I said, well, if I looked at the list, and there's a very long list in an Excel file, which I'm happy to share with Susan if she wants to share it with any of you. It's just this big Excel file. What kind of codes risk adjust? So for illustration only, not comprehensive, I put some of them together here. So on page 21, in the infectious and parasitic disease chapter, and remember, not comprehensive, of course, sepsis and toxic shock risk adjust. Patients in the hospital with sepsis, the hospital coder is going to get that for us. HIV and HIV status both risk adjust, and chronic viral hepatitis. When I look at neoplasms, primary and secondary malignant neoplasms, those things that start with the letter C, and then of course some blood disorders. Garden variety anemia does not risk adjust, so there are really specific types of anemia that risk adjust. Endocrine disorders, of course, diabetes with or without complications or manifestations, and with complications and manifestations carries a higher risk, and of course, morbid obesity. We're going to talk about depression, even though you may not all be treating depression, but substance abuse codes, major depressive disorders, some, we'll see which ones do and don't risk adjust, schizophrenia, and all of the codes in the bipolar disorder risk adjust. Diseases of the nervous systems, Parkinson's we see pretty frequently, epilepsy, and then quadriplegia and hemiplegia risk adjust as well. I'm going to look at diseases of the circulatory system in a little more detail. So take a look at that list, but I'm going to come back to it in more detail on a later page. Diseases of the respiratory system, of course, COPD, all of the codes in the COPD category, J44, risk adjust. For pneumonia, the pneumonia that you would see in the outpatient in the office of an unknown organism, that doesn't risk adjust. Certain types of pneumonia risk adjust. There's mostly going to be conditions that you're seeing in the hospital where you know what the organism is. Diseases of the digestive system, cirrhosis, acute ulcer, of course, Crohn's and ulcerative colitis. In the skin section, really, it has to be a stage 4 pressure or non-pressure ulcer to carry a risk-adjusted score. One of the things I have that we're going to go look at next is for selected specialties. Sometimes I'll ask, send me your most frequently reported ICD-10 codes. And I got one from an orthopedic group, and nothing in their 50 most frequently reported codes carried a risk-adjusted score. So you can see the kind of things that risk adjust, osteomyelitis, necrosis, hopefully rheumatoid arthritis, hopefully things we aren't seeing that frequently, right? GU, acute kidney failure, stage 4 or 5 kidney disease or end-stage renal disease, some congenital malformations that the child carries through their life and that we would continue to report are listed there. And then I mentioned that in the signs and symptoms chapter, almost nothing risks adjust, shock and respiratory arrest, and then severe trauma risks adjust. Skip page 22 and 23 and just take a quick look at page 25. So I got from, this is kind of a blended list from a couple of cardiology practices of their most frequently reported conditions. And notice the first one at the top, atherosclerosis without angina, this I25.10, doesn't have a weight to it. So if you're in cardiology or you're treating patients with these kind of conditions, you can run your list down, your eyes down this list and see what kind of conditions carry a risk-adjusted score. And I've got another list of them in the book as well. COPD, as I mentioned, risks adjust, that came up on their list. So in general, just as a reminder, if you're thinking about cardiology, signs and symptoms don't risk adjust. Some categories in hypertensive chronic kidney disease and hypertensive heart disease risk adjust. The stage 5 or end stage renal disease or heart disease with failure. So not all of those do, but some do. And then take a look on page 27. This was that orthopedic list I talked to you about. Basically, nothing did. Podiatry did have some codes that risked adjust. So in terms of specialties, we not everything that we see is going to carry a risk-adjusted score. So we took a look at the types of diseases that risk adjust in the handout, and if you didn't print it out, you can print it out later. So now I'm going to talk a little bit about diabetes and give some examples for the concepts that I mentioned before. And here's an example where two conditions in the same group carry the same risk-adjusted factor. So type 2 diabetes with diabetic nephropathy and type 2 diabetes with peripheral angiopathy are in the same group. So we've got the code there. They're assigned a group, chronic diabetes conditions, diabetes with chronic complications. They have the same risk-adjusted factor, and it's only counted once. So if they're in the same group, even if you put down 5 diabetes codes, it only counts once. They don't add up. And if we had also at some time during the calendar year submitted type 2 diabetes without complications, it has a lower score. We wouldn't count it if it wouldn't be counted if the higher valued score was submitted, diagnosis code was submitted during the year. So type 2 diabetes without complications has a risk score of 0.104. Type 2 diabetes with chronic complications, 3.18, or with acute complications. And then long-term use of insulin has a risk score of 0.104 as well. So looking at some of the other examples, type 2 diabetes with other circulatory complications, we would use that code if the patient, here I've got an example up on the top of page 11. Patient who's got type 2 diabetes with circulatory complications. Their medication list includes long-term use of insulin. The past medical history notes they had a non-traumatic amputation of the great toe in the last year. So at the top of page 11, the first example I give is just the one at the top of the screen here, type 2 diabetes with other circulatory complications. It gets a weight of 0.318. If, on the other hand, you added in long-term current use of insulin, peripheral vascular disease, and this status code for acquired absence of the left great toe, then your risk score goes up to 1.204. The long-term current use of insulin isn't counted. So that's an example of where two related conditions, the lower valued one isn't counted. It is dropped because we have the higher valued score. So the take-home message with diabetes is if the patient has a complication, you want to make sure you're documenting that and using the most specific code. And if they have related conditions like the peripheral vascular disease or the acquired absence of the toe, use those codes. Here's an example of type 2 diabetes with diabetic nephropathy and chronic kidney disease, stage 5. So once a physician asked me, well, aren't I double counting if I'm using type 2 diabetes with diabetic nephropathy and a chronic kidney disease? And of course, no, because those are two different conditions, and because following ICD-10 rules, I would report both of them. And then BMI of 42, we're going to talk about obesity again. I'm just going to take a quick look at the chat. So someone didn't have, I'm going to go back, someone didn't have the handout, and Tammy is still on the call, and she's going to email that to you as well. So here is an example on the screen of 3 codes that are commonly reported together: hypertension, hyperlipidemia, and diabetes without complications. The only one of those with a risk score is diabetes without complications, the E11.9, and that's a risk score of 0.104. Neither hypertension nor hyperlipidemia have a risk-adjusted factor. However, because we can use diabetes with other specified complication for a patient with diabetes with hyperlipidemia, we can use the E11.69 code, which carries a higher score of 3.18. So that would be the more accurate way to report those conditions. This was an example from a client where they saw that the clinician had reported type 2 diabetes without complications and neuropathy unspecified. So we get a lower risk-adjusted score for the E11.9, but if the physician had selected type 2 diabetes with polyneuropathy, the risk score would have been higher. So use E11.65 for patients with a hemoglobin A1C of greater than 7. We're going to use E11.649 if the patient had evidence of a blood sugar that was less than 70, and then the E11.42 for patients with diabetic polyneuropathy. And I think that comes to the end of the diabetes section. We spent some time on it because there's so many patients with that condition. Now, some clinicians say to me, I don't like to use morbid obesity, E66.01 on the claim form, because the patient sees it in the portal, or we print it out on their clinical summary, and they are unhappy. They come back in from the parking lot and complain. So E66.01, morbid obesity, has a risk-adjusted score assigned to it. So if you have a patient with that condition and you report it, that increases your risk score for that patient. If you use E66.9, obesity unspecified, it carries no risk-adjusted score. E66.01 does. Now you could report their BMI of 41, 42, 43, whatever that Z code is for the BMI, or E66.01, morbid obesity. Reporting both does not increase your risk score because they're assigned to the same group. It's also a rule that you're permitted to use morbid obesity for patients with a BMI of 35 or greater, 35 to 39.9, even though the official definition of morbid obesity starts at 40. If the patient has 2 morbid conditions that are complicated by their weight. So BMI of 37.2, complicating hypertension and COPD. I told her weight was contributing to her coronary artery disease and hypertension. So then, again, you could use this E66.01 code. I know many of you don't want to do that, but I'm just telling you what the rules are related to that. We had looked at some of the examples for cardiovascular conditions, and now I've got a snapshot of them up here. In some of these cases, even the unspecified code risks adjust, and in some cases, the unspecified code either doesn't risk adjust or risks adjust at a lower level. So here we want to count on our cardiologists and sometimes our primary care physicians to select the most specific code possible. So whoever's doing the treatment. Or one of the things that our problem lists can be problematic, if you'll excuse me for saying that, because no one has time to update them. So when the echo comes in and you could update the type of failure or whatever you see on that echo and update that in the problem list, nobody has time to do that. But getting our problem lists as accurate as possible is going to help us in reporting HCCs, in reporting our diagnosis codes in a way that accurately describes the disease burden that that patient carries, because that's what we're trying to do. We're trying to tell the payer what the patient's disease burden is, because at the end of a contract year, the payer is going to look at utilization, quality, outcome, and how sick your population of patients are. For atherosclerosis in the I-70 category, we know that these are very specific codes, pages and pages of them if we're in the book. Sites below the neck risk adjust, and manifestations such as claudication, ulcer, or they do carry a higher score. So here's an example of Coumadin, patient seen for Coumadin clinic. Notice that these status codes, and we're still going to get to status codes, do not risk adjust. So long-term use of anticoagulants doesn't, personal history of pulmonary embolism, but chronic AFib does. So if you were running a Coumadin clinic, it isn't that you would need to report those the AFib every single time, but once in a contract year, you would want to make sure you were reporting that underlying condition. All conditions in the category. So here are two examples. You know, in the hospital, they're always asking the physician, what type of heart failure? Because the hospital DRG system has difference in severity of the DRG that's selected based on the type of heart failure. In the HCC system, it doesn't. Now, I'm not telling you not to be specific about your heart failure. I do, of course. If you're treating it, you want to be specific about it. But all of the codes in congestive heart failure risk adjust, all the conditions, all of the codes in J44 COPD, those all carry a risk adjusted score too. And I'll just say a couple other examples. All the Crohn's disease codes. So some serious chronic conditions, bipolar disorder, as I mentioned, they all risk adjust. Some of them in some other codes, the specific manifestation carries a higher score. So depression, and I believe we have some psychology practices on the line. When we moved from ICD-9 to ICD-10, our codes mapped. And you can imagine for me as a quote unquote lazy diagnosis coder, I was like, yes, they're just going to map across. And then of course, we see the problem with the mapping is that it couldn't be specific, because if we went from 16,000 codes to 70,000 codes, it was impossible for it to be specific. And all of the depression codes mapped to F32.9. And it's written in our systems as depression, primary depression, the blues, different ways that we've assigned words to them. The real definition of F32.9 is major depressive disorder, single episode, unspecified. And it isn't included in an HCC category, and it has 0 weight. Whereas all of the codes in F33, major depressive disorder, recurrent, mild, moderate, severe, all of those risk adjust. And everything from F32.0 to F32.5, major depressive disorder, single episode, mild, moderate, severe, those all risk adjust. So this is the one code if you're using it, and some of your specialties, some of you who are on the line today are not using it, but if you are, F32.9 is the code that we would avoid in terms of risk adjustment. We would try to be more specific. And it was this mapping that got us into trouble with this code, and the descriptions in our EMRs, which are not really accurate. But that's a topic for another day. Now, substance abuse, we know that in the substance abuse chapter, it's defined by what the substance is, and then it's divided into 3 different severities: use, abuse, and dependence. And that's in that order, that's how DSM-5 and ICD-10 consider them. Use is the least serious, abuse is the second, and then dependence is the worst. Here's another one where clinicians tell me, I can't put abuse on there, I can't select that code because the patient goes on the portal or gets their clinical summary and they are some unhappy. In general, use and abuse that are defined as either uncomplicated or unspecified don't risk adjust. If there's a manifestation, if it's that with anxiety, with hallucination, hopefully we're not seeing those in the office, then they do carry a risk adjusted score. And many of the dependence codes do. So F11.20, opioid dependence uncomplicated, does risk adjust. Again, I hear from some of you that clinicians are reluctant to use those codes, but some of those do carry a risk adjusted score. In terms of, and I hope some of you now have the handout in front of you, but if you don't worry, I'm going to talk you through it even without, because the first example is HIV. B20, human immunodeficiency virus, and positive HIV status, each of those codes, B20 and Z21, are in category 1 and carry the same weight. So either one of those carries the same score, and reporting them both in a year only gets you the one score of 0.312. The ICD-10 book tells us to use B20, the disease itself, only if the patient has a manifestation of their AIDS and is being treated for it, or has a history of having been treated for a related condition to their HIV. All of the viral hepatitis codes risk adjust, and I've got those listed on the screen and they're in your handout as well. And then there are some conditions that we would see in the hospital, you know, gram-positive pneumonia, gram-negative pneumonia, sepsis, acute kidney failure. Those acute conditions risk adjust as well. Now I want to talk briefly about compliance, and again, I welcome you, if you have a question, to go up to the top and choose the Q&A and ask any questions that you might have, and I'll answer them before we finish here today. So there are a few compliance issues that we have. So now, if you see a patient in your office and I put the wrong diagnosis on the claim form, as long as it's would be covered for let's say it's an office visit, almost any code supports the medical necessity for an office visit. And if I put the wrong code on the claim form, you get paid the same amount. It's not a compliance issue. It's wrong, but it's not going to get us into trouble. If you select a diagnosis for a diagnostic test that the patient doesn't have because it's a covered indication, of course, that's a compliance issue, but we don't do that. But here's an example where now at the end of a contract year, how sick our patients are is going to determine some percentage. Maybe it's going to be a small percentage, but some percentage of our revenue. So we can't report conditions that aren't accurate anymore. Remember back to that ICD-10 guideline, it said, do not code conditions which no longer exist. Stroke is the most common one I see. The patient had a stroke and now comes in for a follow-up. And I absolutely understand why you do it. You type in the word stroke in your EMR and all the I-63 codes come up, stroke. And they're so complex, we pick the least specific one we can find. If the patient is not currently having a stroke, we should switch to I-69, sequela of a stroke. And here, a patient who has hemiplegia or paraplegia, quadriplegia after a stroke, if we choose one of those I-69 codes, then that risks adjust. But some of the long-term after effects don't risk adjust, and neither does Z86.73, personal history of TIA and cerebral infarction without residual deficits. But don't use I-63 if the patient's not currently having a stroke. Patients seen in the office for follow-up of a TIA, again, we wouldn't use G45 if they're not having a TIA right now. We'd use the Z86.73. In this case, neither of those codes risk adjust, so either one of them, even though it would be incorrect to use G45, here you're not going to get paid more, you're not going to report that the patient is sicker than they are. The neoplasm one we mentioned, patients seen for history of cancer. So surveillance visits and patients who have cancer in their problem lists but don't have evidence of the disease and they're not being treated, we should be switching to the Z85 code. I work with a lot of general surgeons, and when I'm with them in a group giving a presentation, I ask, can you get paid by the payers if you use this Z85 code? And then they're more specific for what type of neoplasm it was. And invariably they say yes. It's not bringing denials. And when I talk to physicians who are reluctant to use the Z85, it's because in the past those visits have been denied. I'm not hearing that from those of you who are in the front line, so to speak. Patients seen after an MI, we use the current MI diagnosis code for the first 28 days, and then after that we switch to old MI. But you report the patient's underlying coronary artery disease or other conditions that they have at that time. Because I-25.2, old MI doesn't risk adjust, so use their underlying conditions, whereas the current MIs do risk adjust. So we just want to make sure we're doing that correctly. In terms of status codes that risk adjust, when you do print out the handout, you'll see that I've got the list of all of the status codes that risk adjust. There were so few of them, I could put all of them in the handout. We coders love our Z codes, don't we? And some of them provide really important information for the payers. If I'm thinking of status codes that risk adjust, which start with the letter Z, the ones that we're going to see frequently and pay attention to, HIV status, encounter for an artificial opening, or the status of an artificial opening. The patient has a colostomy or a tracheostomy. A BMI of greater than 40, we talked about, or a BMI of greater than 35 with 2 chronic conditions. And then I'm going to repeat this. If you use E66.01 or the BMI values, and those change by BMI, for 40 or over, either of those risks adjust, either carries the same weight, they're not additive. So one or the other gets the score. If you have a patient who has a BMI of between 35 and 39.9, and they have 2 chronic conditions that are affecting, that the weight is affecting, then we're allowed to use E66.01, morbid obesity. BMI codes between 35 and 39 do not risk adjust. Long-term recurrent use of insulin, although if the patient has diabetes, the higher valued diabetes score will be credited. Acquired absence of a toe or a foot, so a non-traumatic amputation, and then organ transplant status. So this is what we want to do. We want all of our codes to be specific, but focus on the codes in the problem list that are chronic, long-standing, that the patient's going to have for years, and if they have a manifestation or a complication, make sure that you're using that code. And be as specific as you can about the conditions that you're treating, and hope that your fellow clinicians in other specialties and in primary care will be specific about the codes that they're treating. Remember that we code all documented conditions which coexist at the time of the visit that require or affect patient care or treatment. So if you document in your clinical thinking how it's affecting your care, then we're going to use that. If it has a code with a manifestation, with ulcer, with spasm, with hemorrhage, if that describes our patient, we're going to use that. And then report these conditions annually, even those status codes that don't change. Because, of course, if the patient's HIV positive, that's not going to change next year. But remember that the payer has a short memory, and they won't credit it from last year. We need to report these conditions every year. So we are coming to the end of the time, and I don't see that we have any questions, but I'm going to leave it here just for another minute just in case. And I'm just going to restate what I started with while I wait to see if any of you have questions. And then we'll end the call, even if we only have 4 minutes anyways. We're not going to be that early. In fee-for-service medicine, we're paid based on the CPT code or the HCPC code, and then, of course, any modifier. The ICD-10 code supports the medical necessity, tells the reason for the visit. As we move from to contracts, they call them value-based contracts. We could discuss whether that's a really good term for it, but as we used for contracts where they are looking at other factors, including utilization, outcomes, quality measures, maybe patient satisfaction, how sick your population of patients are makes a difference in terms of how your end-of-year settlement, not current payments, but end-of-year settlement. So, Susan, I don't see any questions. We're coming very close to the top of the hour. I want to thank everyone and for inviting me, and in particular, thanks to Health First.